Zengal diverticulum. Zengal is an outpocket of the posterior triangle constrictor muscles. Symptoms include dysphagia, severe halitosis and bad smell, irritation of food particles. Bacterium pneumonia, when contents of the diverticulum end up in the lung. Diagnosis testing is barium study. Repair is made with surgery. There is no medical treatment of Zengal diverticulum. Tip: do not unnecessarily tube placement or appendoscopy. These are dangerous to people with Zengal diverticulum and may cause perforation. Scleroderma. Scleroderma patients present with symptoms of reflux and have a clear history of scleroderma or progressive systemic sclerosis. They will already have skin thickening and other symptoms of systemic sclerosis. Manometry shows decreased lower esophageal sphincter pressure from inability to close the lower esophageal sphincter. The treatment is put on permanent period. This disorder is simply one of mechanical mobility of the esophagus. Tip: manometry is the answer for achalasia, spasm, and scleroderma. ASS, achalasia, spasm, and scleroderma. Manometry is also diagnosis. Menorrhagic tear. Menorrhagic tear presents with upper GI bleeding after prolonged or severe vomiting or retching. Where retching is followed by a metabolism of bright red blood or by black stool, there is no dysphagia. There is no specific treatment and it will resolve spontaneously. For severe cases with persistent bleeding, either plain injection or liquid cautery can stop the bleeding. Perhaps syndrome full penetration of the esophagus. Now look here. Menorrhagic tear is non-penetrating tear of only the mucosa. Epigastric pain. The epigastric area is the part of the abdominal surface located just beneath the extraparietal portion and between the two sets of ribs above the umbilicus. Pain in the epigastric area is common. Up to 25% of population at some point in their lives generally increased pain by pain or pressure in the esophagus. Epigastric pain area is far less common. Pain with a complaint or sensation that is stated by the patient is not the same as tenderness. Tenderness is finding on examination. Let's see, 44-year-old woman comes and reporting the pain in the epigastric area for several months. She denied nausea, vomiting, weight loss, and blood in the stool. On physical examination, no abnormalities are found. What is the most likely diagnosis? It is functional dyspepsia. That is the most common. In a hospital, you will see far more patients with Ulcer disease, peptic pancreatic disorder, or cancer because those are the ones who are admitted. However, functional non-Ulcer dyspepsia is by far the most common cause of pediatric pain. 59% of all cases, especially age less than 6 years. Functional dyspepsia is virtually never a reason to be admitted to hospital. Now, patients hospitalized with epigastric pain are far more likely to have Ulcers, biliary disease, pancreatic disease, cancer, and gastritis with bleeding if they are hospitalized. How to answer what is the most likely diagnosis about gastric pain? Now, if this is in the history, the most likely diagnosis is pain versus food, 70% gastric ulcer. Pain better with food, 70% duodenal ulcer. Weight loss, cancer or gastric ulcer. Tenderness, pancreatitis. Bad taste, coarse or horse, cup or horse, gastroesophageal reflux. Diabetes, bloating, gastroparesis. Nothing, non-ulcer dyspepsia. Only endoscopy can give a precise diagnosis. Diagnostic test. Endoscopy is the only way to truly understand the etiology of epigastric pain from Ulcer disease. Radiologic and barium testing are modest in accuracy at best. You can biopsy with radiologic testing. Tip: in the esophageal barium study is a good place to start with testing, but in the stomach barium is very poor. Now figure 1.7 cause of abdominal pain by location. Right upper quadrant. Cholecystitis, biliocolic, cholangitis, and purpuric during ulcer because here there is the gallbladder and liver. Upper quadrant there is the spleen, so splenic rupture, IBS, inflammatory bowel syndrome, splenic flexure syndrome. Right lower quadrant is the appendix and ovaries, so appendicitis, ovarian torsion, ectopic pregnancy, and fetal diverticulitis. Left lower quadrant is sigmoid volvulus, sigmoid diverticulitis, ovarian torsion, and ectopic pregnancy. Middle epigastrium shows pancreatitis, heart dissection, ulcer disease. Causes of abdominal pain by location. Treatment of gastric pain starts with propion permanent period. The various medications all have equal efficacy. Additionally, acute blocker, there is nizatidine, famotidine are less effective but work in about 7% of patients. Liquid antacids, same efficacy as H2 blockers. Misoprostol is always the wrong answer. Misoprostol and artefact projectile analog were designed to prevent and steroid-induced gastric damage. When proton pump inhibitors arrived, misoprostol became obsolete and a wrong answer on the test. Gastroesophageal reflux disease. Gastroesophageal reflux disease is the inappropriate relaxation of the lower esophageal sphincter, causing acid content of stomach to come up into the esophagus. Symptoms of GERD are worsened by nicotine, alcohol, caffeine, chocolate, peppermint, date-night meals, and obesity. There are no unique physical findings in GERD. It is a symptom complex most often diagnosed based on parent history. When the diagnosis is not clear, 24-hour parent monitoring may be considered to confirm the etiology. Symptoms include sore throat, bad taste in the mouth, metallic, hoarseness, or cough. GERD may also show redness, erosion, ulceration, stricture, or bad esophagus. Now, what is the most likely diagnosis? GERD is the answer when you see a gastric burning pain running up into the chest. Tip: you do not have to have all these extra symptoms present in order to answer GERD as the most likely diagnosis. 40-year-old man comes to the office with several weeks of gastric pain radiating up under his chest, which becomes worse after lying flat for an hour. He also has a brackish taste in his mouth and a sore throat. What is the next step in management? See lansoprazole. Lansoprazole is a proton pump inhibitor that should be used to control symptoms of GERD when the diagnosis is not very clear, such as in this case. If gastric pain going under the sternum, bad taste, and sore throat, confirmatory testing is not necessary. The two blockers are effective in 70% of patients but are clearly inferior to proton pump inhibitors. Endoscopy does not diagnose GERD and is certainly not necessary when the diagnosis is not so clear. Parents refer to the major anatomic abnormalities of the esophagus and borders in GERD. In GERD, endoscopy indicates when there is signs of obstructions of dysphagia or adenophagia, weight loss, anemia, or heme-positive stools. Endoscopy will show nothing when there is only pyrosis, heartburn. Treatment starts with lifestyle management. Lose weight and obese. Avoid alcohol, nicotine, caffeine, and chocolate or mint. Avoid eating within 3 hours of bedtime. Elevate head of bed 6 to 8 inches. Additionally, in mild or intermittent symptoms, liquid antacids or H2 blockers. Persistent symptoms are esophageal gastritis, esophagitis, proton pump inhibitors all are equally effective. Symptoms unresponsive to treatment. Surgical or anatomic correction to tighten the lower esophageal sphincter. Now, initial fundoplication, wrapping the endocinch, and local heat or irradiation of lower esophageal sphincter causes scarring. In the first one, initial fundoplication, wrapping the stomach around the lower esophageal sphincter. Endositch, use a scope to place a suture around the lower esophageal sphincter to tighten it, and local heat irradiation or lower esophageal sphincter causes scarring. Only endoscopy can determine the presence of Barrett's esophagus. Next topic. Long-term GERD leads to histologic changes in the lower esophagus with columnar metaplasia. Columnar metaplasia usually needs at least 5 years of reflux to develop. There are no unique physical findings or lab tests. Biopsy is the only way to be certain of the presence of Barrett's esophagus and/or dysplasia. This is indispensable because the biopsy-derived treatment, columnar metaplasia with intestinal features, has the greatest risk of transforming into esophageal cancer. Now, each year, about 0.5% of people with Barrett's esophagus progress to esophageal cancer. Findings and management. Finding management. Barrett alone metaplasia, proton pump inhibitors and rescope every 3 to 5 years. Low-grade dysplasia, proton pump inhibitors and rescope every 6 to 12 months. High-grade dysplasia, ablation with endoscopy, photodynamic therapy, radiofrequency ablation, and endoscopic mucosal resection. Now, only Barrett's esophagus, then proton pump inhibitor and rescope 3 to 5 years. If low-grade dysplasia, then rescope 6 to 12 months. High-grade dysplasia, then ablation.